Good afternoon. Thank you for attending the Season 9 premiere of Ocean Grand Rounds. I am your host, William Pinnock, and today I could not be more excited to welcome Dr. Eva Woodward of Central Arkansas Veterans Healthcare System and the University of Arkansas for Medical Sciences as she presents on the 8 mindsets to promote health equity through health services and implementation research. Dr. Eva Woodward is a clinical health psychologist. She uses implementation science and practice, community engaged research, and mixed methods to improve equitable healthcare delivery for groups experiencing disparities. She is a former fellow of the Implementation Research Institute, the NIH Health Disparities Research Institute, a VA Career Development Awardee, clinician, and researcher through the Veterans Health Administration, and an associate professor at the University of Arkansas for Medical Sciences in Little Rock, Arkansas. And you can find her published in such places as Implementation Science, Frontiers of Health Services, and BMJ Open. This session is being recorded. Attendees are muted upon entry, so please pose your questions through the Q&A or chat box. This presentation will last approximately 40 to 45 minutes with 10 to 15 minutes at the end to answer any questions you may have. We will now pass the mic to Dr. Eva Woodward for 8 mindsets to promote health equity through health services and implementation research. Dr. Woodward, the floor is yours.
Thank you so much, William. Okay, how's my audio?
Audio is great.
Okay, then let's make sure I get the proper sharing here. Thank you all for having me. Thank you so much to Ocean for inviting me for Grand Rounds today. I know that as advertised, there were supposed to be 6 mindsets, but I have 8. So let's just be with me on this. Okay. Okay, I want to confirm. William, are you seeing the right screen? Got it. Okay. You know where I'm coming from, and each of you, as I've been exploring some of the work of the people at Ocean, I've been seeing that you all do such special work and such impactful work, and thank you for that. I am excited to be here to share with you what's really special to me, which is all about thinking about how to reduce healthcare disparities and promote health equity. And there's lots of ways to do that, and enhanced or specially focused health services and implementation research is one of those ways. So that's what we're going to dig into today. Okay, some quick disclosures and an important note that the views I share here do not necessarily reflect the position of the U.S. government or the U.S. Department of Veterans Affairs or the University of Arkansas for Medical Sciences. Okay, as we move into thinking about implementing medicines, therapies, screenings, policies, entire programs, that work is really complex. And tackling how to reduce healthcare disparities is also really complex. And so often when people approach that kind of equity work and implementation, there can be a sense of helplessness or overwhelm that's really natural because it's just really complicated. And so I just want to ground us all as you are running from your clinic job or you're coming from another meeting or you're driving right now. I just want to be able to ground first in a mindset that for equitable and just implementation of the innovations that you're trying to get out there to the public, we must really embrace that complexity and realize that these can be career-long, lifelong endeavors. And so as I share with you kind of these 8 mindsets and then some practical ways you might operationalize them or integrate them into your own work, I encourage you to really think about what's the most elegant next step for me. And I love this quote from Adrienne Maray's Brown's book, Emergent Strategy, because you cannot do all things at once, but you can do all things eventually. So take it one step at a time and really think, what's the most elegant next step for me? Out of all these neat things I'm going to hear. What's really the most elegant next step for me right now? Okay. So let's dig in. First, make sure we're on the same page. Healthcare disparities inhibit health equity and justice. So there are some differences in health that exist. Like certain people might be more likely to have tennis elbow than others. And, that's likely due to it being the sports they play. You wouldn't expect to see people who play lacrosse or who swim to have a lot of tennis elbow. And so the difference is explained by the sport they actually play. Um, and health disparities are separated from health differences. They're not simply differences in a health condition. They're concerned with social justice. So health disparities are, you know, differences between two groups on a specific outcome with respect to one group having significantly more advantage, more power, being treated differently than groups who are highly marginalized. And moving toward health equity requires us to reduce and eliminate disparities and in its determinants. So health equity is really if everyone has a fair chance of being well. So as we approach reducing disparities in health care, which are really disparities in access, disparities in the receipt of a treatment. So maybe people are able to get in line for a treatment, but certain groups are less likely to actually receive a treatment than other groups. And the groups that are less likely to have a history of being marginalized in some other way societally. Or healthcare disparities could exist in the quality of care. So let's say that some innovation is actually, people can access it pretty equitably. They even receive it at equal rates across subgroups, but then the quality ends up differing. And that is that, and that would also potentially signal a healthcare disparity. And then the final disparity in healthcare could be that groups are showing differences in outcomes of an intervention. So let's say you are able to, equitably distribute some type of innovation in cancer screening, for example, and everybody has access to it. Um, there's no differences in who receives it by subgroup, and the health screenings are done with fidelity, high quality across all groups. But then actually there's differential actual detection of let's say early stage cancers among some groups. So it indicates that there's actually a problem with the outcomes of the screening, that they might not be as sensitive for some groups as for others. Or maybe some type of therapy you've implemented actually is showing differences in outcomes for some group versus another. And the group who is having the worst outcomes, has a history of experiencing social marginalization in some other realm of society. So you're really wanting to start thinking about detecting the first mindset, which is to detect or anticipate disparities in healthcare delivery for groups experiencing marginalization. And you might already be at this step and you already know they exist. And so this is not your step. This is not your most elegant next step. But this really needs to be the first place you start. And I encourage you to get as precise as possible, because to change that, you'll end up needing to be quite precise. So here are some ideas of how you might do that. Setting up dashboards or reports that assess healthcare disparities by groups with a documented history of marginalization. So, this depends significantly on your setting and the health problem at large. And that area best. And if you don't know that area best, if what we just went over on the last slide, you weren't sure of key, in your area of key disparities, between certain groups based on either their access to innovations that you care about, like a package of cardiovascular risk reduction interventions, or perhaps some mental health therapies, or um, getting started with some preventative infectious disease vaccine. If you're not sure which groups might have disparities, and you're not sure whether there are disparities in accessing it, receiving it, quality of it, or outcomes of it, that really is probably your most elegant next step, is to figure that out from existing literature, but then seeing, you know, also in your own sites, in your healthcare system, in the clinics you're working in, or public health settings, what's going on there? Are those same disparities showing in those places? So here's one example. And then I'm going to ask you a question about this. So, Black and Latino Americans lose less weight than white patients do in white non-Latino patients in behavioral lifestyle intervention treatments. Okay, so that's a thing. Washington, Johnson have documented this in many findings. So let me ask you in the chat, between which groups is there a disparity? Go ahead and put in the chat, between which groups is there a disparity in this example? So if you're just signing on or you're just queuing in the chat, read this example on the screen, of an actual disparity that's documented in a healthcare disparity, and then type in the chat, between which groups is there a disparity? Between which groups of people is there a difference that is not due to patient choice, likely due to some societal disadvantage or marginalization? So the example is, I'm just going to read it out loud. Black and Latino Americans lose less weight than white patients in behavioral lifestyle intervention treatments. Make sure you are chatting to everyone. Okay. I see people rolling in. Oh, I see that someone chatted. Thank you for chatting. You accidentally sent it to the hosts and panelists only. So just in your Zoom chat, there's a little blue box with an arrow, and you can drop down and click everyone. Yeah, there you go. Okay, so there are between which groups there are disparity are in between Black patients and white patients, and Latino and non-Latino patients. Exactly. Mm-hmm. Mm-hmm. Um, oh, interesting. Someone's weighing in between Native American and white patients with preventative screens. You must have some more advanced knowledge of this particular area. Just in this example on the screen, um, this is from existing literature, so you wouldn't, it's already documented out there. And the first thing is to specify between which groups is there a disparity. And that is true in this case among Black and Latino and, uh-oh, my other circle went away. It's between Black and Latino and white patients. So specifically between Black and white patients, but also between Latino and then it should say non-Latino white here as well. So, and you might know of more in your field or more from the literature. But it's important to be precise, to not actually assume. And so this is a racial ethnic disparity that we're seeing here. So let me ask you a second question about this statement. Is this a disparity in the receipt of the weight loss, the behavioral lifestyle intervention treatments, access to it, quality of it, or the outcomes of it? Oh, there's my other little red circle. That's supposed to be up on white up there. Oh, forgive my misplacement. So answer in the chat is this example: Black and Latino Americans lose less weight than white patients in behavioral lifestyle intervention treatments. We know there's a disparity between racial and ethnic groups, specifically Black and white patients and Latino and non-Latino white patients. But is it a disparity in receiving behavioral lifestyle treatments for weight loss, access to them, quality of them, or outcomes of them? So these are the important questions to wrestle with. this is interesting, seeing all of your answers and your thoughts. So, based on just this sentiment that we see um, on, in this statement, we can only infer right now that there is a disparity in outcomes. The outcome being weight loss. So we know that Black Americans are once if Black Americans and white Americans are getting these behavioral lifestyle intervention treatments, that Black Americans lose less weight than white American patients. So that's an outcome, weight loss. Now, someone put in the chat outcomes in this case, but all of those matter. That is true. And because it's very possible that, you know, the outcomes are where we're seeing the disparity, but there could be issues earlier in the flow of patient care, in that they can't access it with equal rates. When they receive it, it's not with this high of quality. Maybe that's actually what explains the poor outcomes. And so that kind of information is what you want to start looking for. You want to start saying, okay, I know right now, based on this literature, there's a lot of literature that says there's differences in outcomes in racial and ethnic groups, specifically these three listed on here, in weight loss in an outcome. And now I might need to figure out why. And so you might want to see what science is out there, either in your system or in the literature at large, on perhaps quality of those of delivering these weight loss behavioral lifestyle interventions, or access to them. And if that's not there, if that's not clear, that might be something you need to examine to detect or anticipate disparities. And that will also, when you start to really specify the scope of the problem, then you can better design implementation efforts to address it. Because if you're trying to get more people into treatment, so that's an access disparity, you're going to use very different strategies than if let's say Black patients and white patients are getting into the treatments at the same, an equitable rate, but they're actually getting worse quality of care. Let's say Black patients are, and then we know then they're actually losing less weight. So then access isn't the issue to focus on. All of them matter, and it's important to be precise which you're focusing on and then what strategies you will use. And so the goal of this first, mindset is to end with an equity-focused implementation goal. So we know already from looking at this example in behavioral lifestyle weight loss treatments that one important area is to reduce racial and ethnic disparities in the outcomes and how effective those are for them. And that might mean investigating earlier in the patient care pathway and looking at the quality of them, or perhaps access to them. I'm not sure, because this is not my area. Okay, so try to detect or anticipate healthcare disparities based on existing data in dashboards and or reports that are already in the literature, or by associations in your health condition or in your system even, and end with an equity focused implementation goal. So then once you've kind of detected what the problem is and you're saying, okay, I get what the issue is here in terms of precision, the groups that are experiencing the disparity, where the disparity is, and in what area. The next step in the next mindset is to think upstream about what is causing inequities or disparities. So now we're moving into a phase of trying to understand why it's there, understanding the problem. So inequities are likely occurring because systems were built on the foundations of inequality and injustice. Not every single system, but many of the healthcare systems and health systems, and in fact, educational systems, criminal justice systems, housing systems that we operate in, at least in the United States, they've actually been built, even if unintentionally, on foundations of inequality. And so then the notion of fitting simply taking and fitting interventions into these systems can sometimes be considered a good thing in implementation. And yet, fitting them into racialized systems that are pretty unjust and structures that were built on inequality may merely perpetuate, and this is an example of racial disparities, they may merely perpetuate racialized differences in access and feasibility within unmodified racialized systems, and it implies conformity to those systems. So, you know, and then the question is like, okay, well, what the heck am I supposed to do? And there's a lot of things to do, but considering the foundations within the systems you're working in are built, and actually bringing air to that and bringing a name to that is a really important step. Because even if we as healthcare professionals and implementers and scientists, or even we as patients, don't have the words for all that, we can kind of feel that and know that. Um, and so it's an important piece of knowledge to make really explicit in what we're in when we're trying to understand a problem, is understanding the history of where it has come from at the system level. But also, a lot of people know and think about social determinants of health. So the conditions in where you live and where you work, but also in your community networks. And then, that can trickle down and affect your individual lifestyle factors. And so thinking about those social determinants of health is also a good place to start to understand why that healthcare disparity exists. So here's some suggestions to think upstream in practice. One is to partner outside health sectors to implement, because a lot of our health issues are not happening in a vacuum. Um, Partnering, across education sectors, as an example, or legal system sectors might be wise in your health area and your health problem. If you have the skills or skills on your team, using system science and what's called agent-based modeling to capture multi-level cause and effect if you're doing capital R research or evaluation. And I haven't gotten a chance to do any of this in my science yet, but I hope in the next 5 years I can. I'll have to collaborate with someone because I don't do those. But that's always a possibility and a good recommendation. And also, if you're doing program evaluation, if you are evaluating implementation, or you're doing implementation research, design questions, data collection, analysis, and interpretation that actually accounts for upstream factors from the beginning. So consider frameworks that actually account for health equity. And I'll show you some examples in a moment. Be really specific about which social determinants of health or which systemic determinants or factors might affect certain health outcomes. So being really precise about what you hypothesize. More suggestions to think upstream in practice. Actually then collect social determinants of health information if you can, and if you want to build interventions or strategies based on that. So if you're looking to measure those things and you're not sure how, working with local anthropologists or working with the data analysts in your area, and people who do a lot of medical record data. And also you can create your own measures, or use measures that exist. The PHENX toolkit from the National Institute of Minority and Health Disparities it's a great repository, the PHENX toolkit. If anybody knows of that, please put it in the chat while I'm talking. And then actually offer interventions for patients struggling with social determinants. And then in your planning meetings, if as you all are actually moving toward a research project, getting up and going, or you're planning for one, or you're moving toward an implementation effort, even if it's outside of research, add an agenda item that says, what other actions might our health system take within our sphere of influence to intervene upon social determinants of health? Lots of possibilities there, some that might be traditional, some that might not be. So here's an example of partnering across sectors for harm reduction among people who are incarcerated. This was led by two of my colleagues at the University of Arkansas for Medical Sciences, Dr. Melissa Zielinski, pictured here, and Nick Zoller. They partnered with the county sheriff's office and applied and received a grant um, to expand the sheriff's reentry program for people incarcerated, reentering civilian life in the community. And so they used all of these different services that really addressed multiple contributors to recidivism, to repeat criminal activity or violating parole. So substance abuse counseling to peer recovery support specialists, so that's like community health workers, Medicaid assisted treatment for people with opioid use disorder, housing support, 12-week classes on trauma recovery. And so you can see they harnessed many systems and partnered across multiple sectors to provide something to incarcerated individuals to actually address some of the reasons that they were in jail in the first place. Not all of them, but some. Okay. So, um, and there's a lot there. There's a lot I just mentioned. And again, think about your sphere of influence and what might be the most elegant next step for you based on where you are and the relationships you have. Next mindset. As you're trying to understand the healthcare disparity, conduct formal or informal diagnostic assessments using implementation frameworks that account for equity related factors. So, this was one of the suggestions in thinking upstream. So there are some implementation frameworks that include equity related factors. So this is what you might use as a determinants framework, not to design evaluations, but to design assessments of barriers and facilitators, you know, strengths and challenges, a needs assessment of why this healthcare disparity exists. So one is the health equity implementation framework, which me and my team adapted and is out there for public use. And then there are many theories of structural violence, intersectionality, policy and governance that can account for more of these multi-level and systems factors in this excellent paper by Snellrud and colleagues that's highlighted. And if you want a practical tool, you can go to this website, and it has all frameworks for implementation research, and it's a lot, but you can search by, I put health equity, and there's around 10 frameworks there, including the ones that are listed already on the screen that might be a better fit for you. And afterward, William, I did not ask you if this was possible, so correct me if I'm wrong, and if not, we'll work on it now. I actually have a free planning worksheet if you want to use the health equity implementation framework for a formative evaluation or a diagnostic assessment, that I've just found really helpful in my own work, that I'm happy to circulate and you can use too. Okay, next mindset. Planning to intervene. So now you're actually okay, I've detected this disparity. I'm planning to intervene. What are we going to do about this? Giving everyone the same intervention or implementation strategy is not always equitable, although it is much easier. So let's take in this visual from the Robert Wood Johnson Foundation. Equality is depicted at the top. You've got 4 people, 4 bicycles. The bicycles are equal. They're all the same. And yet you have a person who uses a wheelchair that can't even get on the bicycle, a person that's much too large that's on the bicycle but looks quite uncomfortable, and then a very short person that is riding it but barely. So imagine that this is a therapy, for example. Let's say it's a physical therapy intervention like falls prevention, and you give the exact same one to all of these people, untailored. You've got some people that can't even use it, and then you've got some people that are quote unquote doing it, but are very likely not getting the same benefits as others. So equity is at the bottom, where the bike actually is a better fit. So the person who uses a wheelchair has a hand trike and they can actually get, aerobic benefit from riding a bicycle. And the smaller person has a much smaller bike. So imagine these are actually implementation strategies. And so you're wanting maybe patients to change something about their behavior and providers to do something differently. And you want to restructure a physical setup in a clinic to make it easier to do certain things, or putting a clinical reminder in the healthcare system, the healthcare record, to prompt nurses to check in on something. If you ask everyone to do the exact same thing with exact same patients and give them no flexibility, they're unlikely to achieve equity with those things. So what do you do about that? Well, if you are more focused on the intervention or the treatment itself or the screening or the medicine or the therapy, you might have to adapt it. And there's existing guidance on how to do that. I've listed, there's the adapt it or ITT model. That's from HIV world, but it's completely generalizable to other settings. And there's a whole video on it on this um, YouTube channel from the CTSA at Columbia. And then my team and I did this using in the paper at the bottom, using community engagement. We adapted an intervention with community members before we proceeded with implementing it. But then as you move on to implementation, you might have to adapt the implementation plan as well. So my guidance there is document what you do and then see if they differ for different groups. So there are some great tools to track or document the strategies you're using. So there's this paper by Rudd and colleagues, and there's an additional file that's an Excel spreadsheet that has an excellent list of implementation strategies, and you can track what you did, and have like maybe periodic intervals like every month or every quarter sampling the people who implemented and asking them what they did and seeing if they differed for different clinics or different groups of people. And then if you know that if you have pre-planned strategies, but you should then document actually if they're going to change. And so Frame IS on the right by Miller and colleagues is a great tool for tracking when the strategies are changed or tailored by who, when, what was the rationale. So if you have pre-planned implementation strategies, you're like, okay, I'm going to use this. I'm going to do these 3 things. I'm going to identify clinical champions and educate clinicians and secure financial funding and create incentives for providers to do this new thing. Then I would encourage you to actually use FrameIS at periodic intervals, like every month or quarter, what have you, to document what changes and why. So you can see if it differs for different groups. So there is always the question, which strategies are best for implementation equity? Here is another mindset about that. There's unfortunately limited research to answer questions about which implementation strategies are effective to promote equity. However, there are signals from existing research areas that some approaches might be key to improving equity. And some of this work is forthcoming, led by some of my colleagues in the VA, actually. It's just not out there yet. One thing that's seen as pretty important is tailoring. So again, what's the difference between equality and equity? Not everybody gets the exact same thing, and you do that by tailoring strategies. And actually, tailoring is appearing pretty important across the board for implementation success. And you can incorporate into your regular implementation team meetings. How could this strategy be a better fit for the group that we know is experiencing disparities in our health system? And you could have that as a regular implementation planning conversation to prompt you to tailor. Here's for future reference. I'm not going to read all these, but this is Eva's short list of possible implementation strategies for equity based on some of the signals in research. There's so much research that I did not try to cite it on here. You might see some that you're doing or might see some that look unfamiliar. Either way, remember to consider tracking any adaptations you make to it using FrameIS. Okay, now you see at the bottom, there's one bullet point on here, engage end users in implementation processes. This has warranted to me its own mindset. Engaging end users affected by the health problem is the gold standard in health disparities research, and it probably should be in implementation research as well. So end users, in our case, like in OCHIN, I'm guessing are patients. You can correct me if I'm wrong. So, not engaging end users or patients in their own healthcare, but rather engaging them in the process of designing how the services are delivered. Okay, I can finally open the chat. Nothing about me without me. Exactly. Nothing about us without us, which comes from disability advocates from long ago. And I'm very happy to say that we brought that I have a practical tool for you on this, and that we brought a lot of the principles from the disability advocacy movement into those tools. So, why is this important? You've got this comic here. You've got these grown-ups that made a mobile to hang over their baby's crib, and they're like, I love this. This was a great idea for our baby. Yes. And the end user, the baby, is looking up, and all they see are butts. So sometimes, sometimes those of us working in a health system, those of us doing the research, we think this is like the best idea. We think this is really good. But if we neglect the end user input, if we don't talk to the baby, or if we at least don't prototype what it might be like to be the baby, like lay down on the ground and look up at the thing we just created, put ourselves in their place, we are very unlikely to realize that sometimes the stuff we're designing just has people looking at butts. It's just, and you know this from your lived experience. Everyone here, and this is an assumption, if you are in a health system, if you're in Ocean, if you are employed, I'm hoping you have used your insurance, you have gotten health care, you've been a patient somewhere. How many times have you walked through that system? You filled out a form, or you've gone through a procedure, or you were waiting after something, or you were in the hospital, and you're like, did they think this through? This is so humiliating or extremely like poor design. Of course they thought it through, but they didn't think it through from your perspective. So let us give that to each other. Let us give that to the people in the world. Now, the question is, when you're rolling out, when you're doing implementation, how? Well, my team and I developed tools on how to engage patients who've been marginalized in implementation processes. So again, not in their own healthcare. It's engaging them in actually quality improvement or systems redesign or implementation strategies. A hospital middle manager we interviewed said, we would really love to do that, but we just don't know how. So my team and I spent 18 months doing a lot of work, really rigorous process to develop these tools published in this paper called Consumer Voice. And this was funded out of my work at VA, but is totally free and is totally generalizable to any setting. So we have a VA version, which is fancy, but I didn't put it here because I am assuming many of you are not working in the VA if you're working at Ocean. We also have a Google Drive version, and it is very free and simple because we had $0 to make it. We are in process of trying to put it on a public facing website fancier, but for now you've got the Google Drive. Take your phones out, put your camera up to the QR code. I'll give you a moment to do that. And those are freely available to you to use. Now, they are not about implementation, but they are about community or consumer engagement in implementation. And they really draw from principles of community-based participatory research. They draw from principles of community organizers and of many activist groups, such as the disability rights advocacy movement, Nothing About Us Without Us. Okay, and there's that link, and I'm sure you guys will get these slides. Okay, now that was when you did stuff. Everything we just talked about was doing stuff. It was actually using strategies to intervene on the healthcare disparity. So you detected and you got really precise about what your equity-focused implementation goal was. You then tried to understand it with good diagnostic stuff focused on equity, and then you made really thoughtful plans about what strategy to use to reduce it. Now, one mindset is always measure if it's working. Measure if you're moving toward equity and implementation. So whether you're doing this in a quality improvement way or a research way, you can use many frameworks that are out there to design your measures. So measure how implementation affects equity outcomes by assessing concepts from some of these frameworks. There's this extension of one called REAIM. So you might have heard of REAIM, which assesses certain things. If you haven't, it's no big deal. But there is an extension of REAIM to focus on sustainment and equity in this paper, and it's a gem. Go to table 2 if you decide to read that paper, okay, by Shelton and colleagues. There's also this paper by Slava Schmalbeck and colleagues. And actually, this one has a lot of things, but the thing that's related to evaluation and to designing your metrics is in table 3. Okay, straight in table 3. And then just a good think piece on metrics is from Bauman and Cabasa in 2020. So let's take a look at an example. So here's an example of measuring equity-focused implementation outcomes. Okay, so this is I just came up with some examples from that REAIM equity extension. I used their table and I thought about the case of antibiotic prescribing for children with acute respiratory tract infections. So this is not my area either, but it is an area that people are concerned about. Basically, kids with these acute respiratory tract infections that some care providers are overusing antibiotics and creating more antibiotic resistant strains of bacteria. I don't know. I'm not sure. Um, but I know it's a problem because it's causing more health problems and not always resolving the infections. So let's say that you were trying to do an implementation initiative focused on improving like more appropriate or suitable antibiotic prescribing for kids with this condition. So let's say you wanted to study how many kids you reached, but make that equity focused. So you wanted to make sure that you actually reached more kids than currently were getting, appropriate antibiotic prescribing. So you would ask, was there a meaningful reduction in children with inappropriate antibiotic prescribing after 12 and 6 months of whatever implementation strategies you used? So that's reach. Was there a meaningful reduction in the kids that were getting the bad version of antibiotic prescribing? That's reach. But to make it reach equity, you might ask, and were there larger reductions for children based on insurance status or family income? Or you might even ask the first question and say, and stratify them, the groups based on insurance or family income. Again, you don't just want to like look willy-nilly, but you might want to make the decision to look at different subgroups based on the family's insurance status or their income based on other information you have, such as we looked our preliminary data showed that actually there already were disparities in whether children were more or less likely to receive the right antibiotics and there was some difference based on their family's insurance status or their family's income. And so then you'd want to examine that when you look at your outcomes. So let's do another example in this test case, adoption. So adoption is when, let's say in a healthcare system, the provider is doing more of the thing you want them to do. Okay, they've adopted it, not the patient, but the provider. Your first question might be, what proportion of providers increased appropriate antibiotic prescribing to at least 25% of their eligible children patients, eligible pediatric patients? Okay, that's an example. If they increased it by at least 25% after we gave them these implementation strategies, that's a win. Here's an equity-focused way to examine adoption. Ask that first question and then say, and then were there any differences in provider adoption between sites serving mostly urban or mostly rural regions? Again, you don't want to just like pick, geographic region willy-nilly. You'd want to have some indicator you might be looking for that. Okay, so that's an example. Now, final mindset is really one to do throughout. Acknowledge and plan for uneven power, privilege, and oppression of yourself, your team, and the communities you're working for. So, this doesn't, there can often be power imbalances, between people in a system like OCHIN, and communities they serve. And that can also be, within your team based on the different lived experiences and different power within your team. It might also be coming from the community toward people at your team for some reason, based on everyone's lived experience, identity, and the privileges that they hold or the power that they hold. So our process of inquiry, whether we're clinicians, whether we are implementers, facilitators, whether we are researchers, our process of inquiring and producing knowledge is totally influenced by our own lives. Our systems in place by those who came before us, and thus our biases, but also their biases. So it's very possible that even the questions we're asking can be biased. The potential solutions we come up with, the strategies we design, and the things we measure can be narrowed or looked at in a deficit way or biased in some way we can't even see because of the systems we're working in or our own lives. And so it's so important to critically self-reflect. Um, and there are many ways to do that throughout, just as common practice in your teams. There's many options here on the left. I have done or practiced all of them myself. Some I have liked more than others. Um, you can do self-assessments, you can do some reflective writing, get consultation, um, and you can do that privately. You can do some of these with a peer, small groups on a team, or really engage with a supervisor or role model in these ways. So there's one example of how my team and I reflected on power imbalances. Now, we specifically practiced something from our anthropology, and I saw in the chat, shout out to our sociology colleagues as well, called reflexivity. And reflexivity is an approach for acknowledging scientists' own positions in the world, including their own understanding and their limits of how they view their phenomena of inquiry. So there's a publication here of my team and I were doing this as we were first engaging communities in an implementation science effort in pre-implementation. If you wanted to read about our experience, but maybe you've already got a community engaged researcher on your team or an anthropologist or a sociologist and ask them and they will guide you. Now, those are all the mindsets with some practical tools. And I'd like just to give you 30 seconds of silence before we jump into Q&A. What is the most elegant next step for you? From everything you talked about, your sphere of influence, where you are, what might be the most elegant next step for you? And I'd like you to actually email it to yourself or to write it down. Let's just take 30 seconds of quiet and then we'll go into Q&A.
And thank you, Dr. Woodward, for that
Hi.
fantastic presentation. And what a way to start our ninth season of Ocean Grand Rounds. And thank you to
Yeah.
everyone who attended today's session. Please be sure to follow Ocean on Instagram at Ocean Network and over on LinkedIn. In addition, head over to ocean.org and advancedcollaborative.org to read the latest on our research studies, blog posts, and upcoming events. And don't forget to visit our Ocean YouTube channel to catch up on those past Grand Rounds presentations. And Ocean Grand Rounds will be back on October 24th with Dr. Lynn DeBar of Kaiser Permanente Center for Health Research as she presents on the findings from the Back on Track study. Invitations to this presentation will be sent 2 weeks prior to the event, but if you're not on our mailing list and are interested in attending this or any future Ocean Grand Rounds, please email me at grandrounds@ocean.org. That's grand rounds, all one word, grandrounds@ocean.org. So from all of us at Ocean and Dr. Woodward to all of you, have a wonderful rest of your day and stay healthy out there.
Thank you, William, for all your help. Thank you, Corbin.
Thank you, Dr. Woodward.
Okay. Bye.
Bye.